Hi, this is the second part of neonatal seizures in which we will discuss the management of neonatal seizures. So, the first thing that we need to do is the initial medical management. The first step in the management of seizure is to ensure the airway, breathing, and circulation to nurse the baby in a thermoneutral environment. Fine. That is again the TABC. Oxygen should be started. IV access should be secured. Blood should be collected for glucose and the other investigations. A brief relevant history should be obtained and a quick clinical examination should be performed. Brief relevant history and a quick clinical examination. These steps should not require more than 2 to 5 minutes. Okay. Now the second thing is correction of hypoglycemia and hypocalcemia if there is any. If point of care glucose test shows hypoglycemia, or if there is no facility to test the blood sugar, immediately we need to provide what 2 ml per kg of 10% dextrose should be given as a bolus injection, followed by a continuous infusion of 6 to 8 mg per kg per minute. If there is hypoglycemia. So in hypoglycemia condition, this is how the management needs to be done. 2 ml per kg of 10% dextrose as a bolus injection, followed by a continuous infusion of 6 to 8 mg per kg per minute. If hypoglycemia has been treated or excluded as a cause, the neonate should receive 2 ml per kg of 10% calcium gluconate IV over 10 minutes under strict cardiac monitoring. Fine. So if hypoglycemia is not the cause, then we need to suspect hypocalcemia as the cause, and for that we need to give 2 ml per kg of 10% calcium gluconate IV over 10 minutes under strict cardiac monitoring. If the serum calcium levels are suggestive of hypocalcemia, the newborn should receive calcium gluconate at the 8 ml per kg per day for 3 days. Okay, if there is significant hypocalcemia which is seen, then the newborn should receive calcium gluconate at 8 ml per kg for 3 days. If the seizure continue despite the correction of hypocalcemia, then 0.25 ml of magnesium sulfate should be given intramuscularly. If the hypocalcemia is not being treated by giving calcium IV calcium gluconate, then that is the last modality. Now, if the baby is having seizure and if there is any history of perinatal asphyxia and all, then most likely it is due to HIE. The seizure is due to HIE. But the first thing we need to do is control the seizures. For that, anti-seizure medications are needed. They should be considered in the presence of even a single clinical seizure, because clinical observation tend to grossly underestimate the electrical seizures, and facilities for the continuous EEG monitoring are not universally available. Right. So if we can grossly see a seizure, then the electrical seizure which already will be happening would be way more than what we actually see. Like it's the tip of an iceberg kind of situation. So here, because the EEG monitoring is not universally available, so we have to treat even a single seizure episode that we can see. If amplitude EEG is being used, eliminating all the electrical seizure activity should be the goal of ASM therapy. Anti-seizure medication should be given if the seizures persist even after the correction of hypoglycemia and hypocalcemia. Phenobarbital. It is the drug of choice in neonatal seizures. Okay. The dose is 20 mg per kg IV slowly over 20 minutes, not faster than 1 mg per kg. This achieves a blood level of 20 microgram per ml. Close respiratory monitoring is required during the administration of the phenobarbital. If seizures persist after completion of the loading dose, additional dose of phenobarbital 10 mg per kg may be used every 20 to 30 minutes. Okay. This additional dose of phenobarbital 10 mg per kg may be used every 20 to 30 minutes until a total dose of 40 mg per kg has been given. The maintenance dose of phenobarbital is 3 to 5 mg per kg per day in 1 to 2 divided doses starting 12 hours after the loading dose. So this is how phenobarbital is given. Okay. Recent evidence show that the risk of the seizure recurrence may not be high even in the absence of maintenance dose of phenobarbital in the late preterm and term infants with the seizures. So how are we going to give? Let's see again. How are we going to give the phenobarbital? So firstly, there it is, the drug of choice. We need to start with a dose of 20 mg per kg IV, slowly over what? 20 minutes. At the rate, maximum rate is what? Maximum rate is 1 mg per kg per minute. This is given slowly over 20 minutes, right? Then close monitoring needs to be done. But if the seizures persist even after giving this loading dose, this is the loading dose, then we have to give the second loading dose and the third loading dose. There can be 3 loading doses. So after giving first loading, we can give second loading of 10 mg per kg, again over 20 minutes approx, and after 20 to 30 minutes of giving the first load. Okay, we can even repeat this second dose, this loadings of 10 mg per kg, because total we can give 40 mg per kg. Okay, then we can repeat this phenobarbital dose. Ten mg per kg may be given even again. So now this is total of 40. This is the maximum. 40 mg per kg is the total that we have to give, and then we need to start the maintenance dose. Maintenance dose need to be started after giving first load. If we are requiring the second load also, then we have to start the maintenance. And for the maintenance dose, ranges 3 to 5 mg per kg per day. It can be given in OD or BD doses. Mostly BD is preferred. And when we have to start this maintenance dose, that is 12 hours after the loading dose. Okay, so this is how the phenobarbital is given. First line anti-seizure medication evidence and recommendation. A Cochrane review found only one RCT that showed comparable seizure control with the phenobarbital and the phenobarbital, controlling seizure in only half of the cases. Another randomized trial conducted in India included that the phenobarbital was much more effective for seizure control as compared to phenytoin. Based on the available evidence, the 2011 WHO guidelines on the neonatal seizure recommend phenobarbital as the first-line agent for the management of neonatal seizures. So this was the first drug that we have to use for the neonatal seizures. It's phenobarbital. Now second drug that can be used if the seizures are not being stopped after using the phenobarbital is the phenytoin. So phenytoin is indicated if the maximal dose of phenobarbital, that is 40 mg per kg, fails to resolve the seizure, or earlier if adverse effects like respiratory depression, hypotension or bradycardia ensue with the phenobarbital. Okay, phenytoin is given when maximum dose of the phenytoin is given when maximum dose of phenobarbital has been given and it failed to resolve the seizure, or when the earlier if the adverse effects like the respiratory depression, hypotension or bradycardia are seen with the phenobarbital. The dose of 20 mg per kg at the rate of not more than 1 mg per kg per minute under the cardiac monitoring. This is the same as that of phenobarbital. Dose is what? 20 mg per kg IV at the rate not more than this under the cardiac monitoring. Phenytoin should be diluted in the normal saline because it is incompatible with the dextrose. This is something important that we should keep in mind. A repeat dose of 10 mg per kg may be tried in the refractory seizures. The maintenance dose is again 3 to 5 mg per kg per day, maximum of 8 mg per kg per day in 2 to 4 divided doses. Oral suspension has a very erratic absorption and should be avoided in the neonates. Moving ahead, so then there's a flow chart on how to manage the neonatal seizures. Let's read it. So if a neonate presents with seizures, first we have to identify and characterize the seizure, secure the airway, optimize the breathing, circulation and temperature, start the oxygen if needed, secure the IV access and take the blood samples for the baseline investigations including the sugar, calcium, magnesium, sodium, potassium, arterial blood gas, hematocrit in the sepsis screen. If hypoglycemic, blood sugar less than 40 mg per deciliter, administer 2 ml per kg of 10% dextrose bolus, followed by a continuous infusion of 6 to 8 mg per kg per minute. This we have already done. If the blood sugar is in the normal range, check the blood glucose. If abnormal, give 2 ml per kg of the calcium gluconate IV under the cardiac monitoring. Fine. So in hypoglycemia we saw hypoglycemia when we have to consider less than 40 mg per dl, we have to administer 2 ml per kg of 10% dextrose bolus, followed by a continuous infusion of this 6 to 8 mg per kg per minute. If the blood sugar is in normal range, then we have to check this calcium, and if abnormal, give 2 ml per kg of the calcium gluconate, 10% IV under cardiac monitoring. If the seizures continue despite the correction of hypocalcemia, if the hypocalcemia has been find out as the definitive cause, then only we have to give 0.25 ml per kg of 50% magnesium sulfate intramuscularly. In neonates, if the seizures persist, the first line we already saw in the anti-seizure medication is the phenobarbital of 20 mg per kg IV over 20 minutes. If the seizures continue, we can repeat the phenobarbital dose of 10 mg per kg per dose until the cumulative is 40 mg per kg. This all total. So, 2 doses of 10 ml per kg can be given. Even after this, seizures continue, then we have to administer phenytoin 20 mg per kg IV slowly over 20 minutes under the cardiac monitoring, or we can even start with levetiracetam 20 mg per kg slowly over 20 minutes. Repeat the phenytoin 10 mg per kg dose. Repeat levetiracetam 20 mg per kg dose until a maximum dose of 60 mg per kg. So the maximum dose of levetiracetam is 60. So in levetiracetam also we can give total 3 doses. Okay, total 3 doses of levetiracetam can be given, as maximum is 60 mg per kg. Then even after all this phenytoin or levetiracetam, seizures continue, then we have to consider lorazepam or midazolam bolus and midazolam infusion if needed. And after this also, if the seizures continue, then we have to consider other anti-epileptic drugs like the pyridoxine and exchange transfusion. And if seizures are controlled, then when AED, anti-epileptic drugs slowly, wean the anti-epileptic drugs slowly to maintenance phenobarbital. Now, fosphenytoin, the prodrug of the phenytoin, does not cause the same degree of hypotension or cardiac abnormalities, has high water solubility, can be given IM also. This fosphenytoin can be given IM also and is likely to lead to soft tissue injury when compared with the phenytoin. Less likely. Okay, it is less likely. So it's better than phenytoin. It is dosed in the phenytoin equivalence of 1.5 mg per kg of fosphenytoin is equivalent to 1 mg per kg of phenytoin. Now the third kind of drugs is benzodiazepines. After phenobarbital, phenytoin, now it's benzodiazepines. This group of the drug may be required in up to 15 to 20% of the neonatal seizures. Fine, now let's start with benzodiazepines. This group of the drugs may be required in up to 15 to 20% of the neonatal seizures. Fine, it is required in only up to 15 to 20% of the neonatal seizures. The commonly used benzodiazepines are the lorazepam and midazolam. Diazepam is generally avoided in neonates because of its short duration of the anti-epileptic effect but very prolonged sedative effect, narrow therapeutic index, and the presence of sodium benzoate as a preservative. So for all these reasons, diazepam is not used. Why? Why is it avoided? Because of its short duration of anti-epileptic effect, very prolonged sedative effect, and narrow therapeutic index, presence of sodium benzoate as the preservative. Lorazepam is preferred over the diazepam as it has a longer duration of action, results in less adverse effects like sedation and cardiovascular effect, and midazolam is the faster acting than lorazepam and may be administered as an infusion. It causes less respiratory depression and sedation than the lorazepam. However, when used as a continuous infusion, the infant has to be monitored for the respiratory depression, apnea, and bradycardia. Equipment for the resuscitation and assisted ventilation should be available at the bedside of all the neonates given multiple doses of the anti-epileptic drugs. Fine. So if we are giving midazolam, which is the faster acting than lorazepam, also if there is It causes less respiratory depression and sedation than the lorazepam. However, when a continuous infusion of midazolam is being used, the infant has to be monitored for the respiratory depression, apnea, and bradycardia. So, equipment for the resuscitation and assisted ventilation, they should be available at the bedside. And all the neonates given multiple doses of this anti-epileptic drug. The dose of these drugs are given below. Lorazepam. What is the dose of lorazepam? It is given in the dose of 0.5 mg per kg IV boluses over 2 to 5 minutes and may be repeated. And midazolam is given in the dose of 0.15 mg per kg bolus followed by infusion of 0.1 to 0.4 mg per kg per hour. This is the dose of midazolam. 0.1 to 0.4. The expected control rate of the neonatal clinical seizures to anticonvulsants is 40% to the initial of 20 mg per kg lowering dose of the phenobarbital, 70% to a total of 40 mg per kg of phenobarbital. That means 70% of the seizure will be controlled by this 40 mg per kg of phenobarbital, 85% to a 20 mg per kg of phenytoin, and 95 to 100% to a 0.05 to 0.1 mg per kg of lorazepam, which is the IV bolus form. Okay. However, as far as the electrical seizures are concerned, a combination of phenobarbital and the phenytoin will achieve seizure control in only around 60% of the cases. Okay, in electrical seizures are concerned. Now coming to the fourth drug, which is the levetiracetam. First drug we read about was the phenobarbital, then phenytoin, then benzodiazepines, and then levetiracetam. So this levetiracetam is increasingly being used in the neonates as the first line or the second line drug based on its better safety profile and less drug interactions. Seizures control of more than 80% has been reported with the dose of 20 to 50 mg per kg per day. This is a very good seizure control. With what? Dose of 20 to 50 mg per kg per day. However, in the recent Neo-Lev2 RCT, phenobarbital was found to be more effective than levetiracetam. There is a great interest in use in its neonates. However, randomized studies have not been performed. On the contrary, a recent meta-analysis reported that there was no significant difference in the efficacy between levetiracetam and the phenobarbital, but levetiracetam use was associated with fewer side effects. Even though the evidence regarding the efficacy is conflicting, giving the better safety profile in terms of respiratory and cardiovascular compromise, levetiracetam may be appropriate second-line agent for the neonatal seizures. Now coming to this box which is given, second-line anti-seizure medication, evidence and recommendation. Cochrane review found one study that randomized infants who failed to respond to phenobarbital to receive either lidocaine or midazolam as the second line agents. There was a trend for lidocaine to be more effective in reducing the seizure burden, but both the groups had similarly poor long-term outcomes assessed at 1 year. Based on the availability of evidence, the WHO guidelines on the neonatal seizures recommended either midazolam or lidocaine as the second line anti-epileptic drug in the neonatal seizure. However, given the lack of robust evidence and the constraints involved in providing respiratory support or monitoring most neonatal units in India, it seems appropriate to use phenytoin as the second line agent in the neonates with seizures. Recent evidence has shown that the levetiracetam has a good safety profile, with a systemic review showing no difference in efficacy when compared to phenobarbital, and a recent randomized trial reporting higher efficacy of levetiracetam for the term asphyxiated newborns. Phenobarbital has some side effects such as the hypotension and the respiratory depression, and it can accelerate the neuronal apoptosis in the immature brain. Thus, it is more appropriate to use levetiracetam as the second line agent until a more evidence is available regarding its efficacy with the first line drug phenobarbital. This is just some studies that were done, and this is important for us to know. Moving ahead, anti-seizure medication for seizures refractory to the above treatment. So we have read 4 drugs till now. Fine, and if a seizure is refractory to all these, then we call it a refractory seizure. In exceptional circumstances, when the seizures are refractory to phenobarbital, phenytoin, midazolam, and the following drugs may be tried. First one is the lidocaine, second is the paraldehyde, and third is the sodium valproate. So these drugs can be tried when seizures are refractory to phenobarbital, phenytoin, and midazolam. Why is levetiracetam not written? Because levetiracetam was an option with this phenytoin only, no? Right. So let's see which drugs can be tried. First one is the lidocaine. It is usually administered as a bolus dose of 4 mg per kg IV, followed by an infusion rate of 2 mg per kg per hour. It is tapered over several days. Adverse effects include arrhythmias, hypotension, and seizures. It should not be administered with phenytoin. It should not be administered with what? With phenytoin. Paraldehyde, a dose of 0.1 to 0.2 ml per kg per dose may be given IM, or 0.3 ml per kg per dose mixed with the coconut oil, and 3:1 ratio may be used by the rectal route. Additional doses may be used after 30 minutes and 6 hourly. Adverse effects include what? Pulmonary hemorrhage, pulmonary edema, hypotension, and liver injury. These are the serious side effects caused by paraldehyde, mostly related to lungs, that is pulmonary hemorrhage, pulmonary edema, hypotension, and liver injury. Then comes the sodium valproate. Per rectal or IV route may be used in the acute condition. The dose is 20 to 25 mg per kg, followed by 5 to 10 minutes per kg every 12 hours. It should, however, be used with caution in newborns, given the uncertain risk of hepatotoxicity. So there is a risk of what? There is a risk of hepatotoxicity. Other drugs which can be used are fourth, vigabatrin and topiramate. Vigabatrin, it has been used in neonates with infantile spasm at the dose of 50 mg per kg per day. Now starting with the topiramate, it shows promise in the neonatal seizure because of its potential neuroprotective effect against the injury caused by the seizures. It has been, so this is a very new thing, that this topiramate has what? Has a potential neuroprotective effect against the injury caused by the seizures. It has been used for the refractory infantile spasm in infants. The higher volume of distribution compared with the other drugs require higher initial and maintenance dose of approximately 3 mg per kg. So it has a very high dose, maintenance dose of this. Now coming to other therapies like pyridoxine and exchange transfusion. So pyridoxine, a therapeutic trial of pyridoxine is reserved as a last resort in the refractory seizures. Okay, this is what? This is the last resort, a therapeutic trial of pyridoxine. The IV route is preferred method. However, suitable IV preparations are not universally available. Hence, IM route may have to be used. 1 ml of injection neurobion has 50 mg of pyridoxine, and 1 ml each may be administered both sides in either gluteal region or anterolateral aspect of the thigh. It should be given with the continuous monitoring, as hypotension and apnea can occur. Okay, so it should be given with what? Continuous monitoring. Now coming to the exchange transfusion, this is indicated in the life-threatening metabolic disorders, accidental injection of local anesthetics, and transplacental transfer of the maternal drugs like the clopramide and bilirubin encephalopathy. So in all these cases, exchange transfusion is done. Let's read these cases again and highlight them. Life-threatening metabolic disorders, accidental injection of local anesthetics, transplacental transfer of the maternal drugs like chlorpropamide and bilirubin encephalopathy. Now there is something called as the maintenance anti-epileptic therapy. Principles of the ASM used in the older children and the adults are applicable to neonates also. Monotherapy is most appropriate strategy to control the seizures. Okay, monotherapy is the most appropriate one to control the seizures. Attempt should be made to stop all the anti-epileptic drugs and wean the baby to only phenobarbital at 3 to 5 mg per kg per day. Fine. If the seizures are uncontrolled or if the clinical toxicity appears, a second anti-seizure medication may be added. The choice may vary from phenytoin, carbamazepine, and valproic acid. Now, when to discontinue this anti-seizure medication? This is highly individualized and no specific guidelines are available. The goal is to discontinue the anti-seizure medication as early as possible. We usually try to discontinue all the medications at discharge if the clinical examination is normal, irrespective of etiology and EEG. Fine. We usually try to discontinue all the medication at discharge if the clinical examination is normal, irrespective of etiology and EEG. A recent retrospective comparative effectiveness study demonstrated that the discontinuation of the anti-seizure medication at discharge for acute symptomatic neonatal seizure had no difference in the functional neurodevelopmental outcome and the risk of epilepsy at 24 months of the age when compared with the continuation of anti-seizure medication at discharge. So what's written here is, there was a study done in which they compared the two groups, one in which the anti-seizure medication was stopped at the discharge and one in which the anti-seizure medication was stopped at the discharge and one in which it was continued, and both had the almost same chance of epilepsy at 24 months of age. This is what is written. So if the neurological examination is persistently abnormal at discharge, anti-seizure medication is continued and the baby is reassessed after 1 month. Fine, this is important. We should know that. That if the neurological examination is persistently abnormal at discharge, anti-seizure medication is continued and the baby is reassessed after 1 month. If the baby is normal on examination and seizure free at 1 month, phenobarbital is discontinued over 2 weeks. Fine. If the neurological assessment is not normal, this is from the second condition. If the neurological assessment is not normal and EEG is obtained, if EEG is not overtly paroxysmal, phenobarbital is tapered and then stopped. If the EEG is overtly abnormal, the infant is reassessed in the same manner at 3 months and then 3 monthly till 1 year of age. Let's look at this image. This is about the weaning of anti-seizure medication. So newborn was on anti-seizure medication. So stop the anti-seizure medication immediately if the seizures are attributed to the transient metabolic abnormality. In other cases, wean all the anti-epileptic drugs except the phenobarbital once the seizure is controlled. Fine. We can stop all the other anti-epileptic drugs except the phenobarbital. Now perform the neurological examination prior to discharge. If the neurological examination is normal, then we can stop the phenobarbital prior to the discharge, and if it is abnormal, then we have to continue the phenobarbital for 1 month. Again, we repeated the neurological examination at 1 month. Now this time the neurological examination comes out to be normal, then we can taper the drugs over 2 weeks. But if the repeat neurological examination at 1 month is abnormal, then we have to evaluate with the EEG. Normal EEG, then taper the drugs over 2 weeks. Abnormal EEG, continue the drugs and reassess at 3 months. And we have to reassess like this every 3 monthly till 1 year of age. This is how the tapering of the anti-seizure medication is done. So yeah, this was all about management of neonatal seizures. Thank you.